مع left ventricular hypertrophy in echo. Is there a place for cardiac MRI مع الدكتورة منى عبد العزيز. منى مشهورة قوي. منى مشهورة قوي. سيلبرتي يا منى.
Good afternoon, my dear professors and colleagues. I'm Mona Abdel, assistant lecturer at Ain Shams University. Our talk today is about the left ventricular hypertrophy and the role of MRI in its diagnosis and management. I hope it will be simple too for you. First, what is the left ventricular hypertrophy? It means that the left ventricular mass is increased, and it's a common condition, usually due to systemic hypertension, and it increases with multiple risk factors such as progression of the age and the obesity. So what are the most common causes for left ventricular hypertrophy? First, the most common cause is the valvular heart disease. And our initial study that we should start with is echo, and it is a standard investigation for initial assessment and for measuring multiple parameters such as velocity, the mean gradient, and the ejection fraction, and the valvular area. So what is the MRI added role for the valvular heart disease? It provides more detailed assessment of the valve and the left ventricular function, and can accurately determine the size of the aortic root in the aortic valve diseases, also assess the regurgent parameters, determine the ejection fraction, measuring the left ventricular size, and it's most important is the detection of the underlying etiologies. وأنا كنت عايزة البوينتر بس. خلاص اوكي خلاص كنت عايزة البوينتر من هنا. And the second most important and most common cause is the hypertrophic cardiomyopathy, which is defined by the left ventricular hypertrophy, which cannot be explained by any other cardiac or systemic disease. And it is one of the leading causes of sudden cardiac death in infants, teenagers, and young adults. So the HCM has several subtypes. We'll discuss some of its important subtypes. The first is the asymmetrical hypertrophic cardiomyopathy, which is the most common variant, 60 to 70% of the cases. It is defined as the disproportionate septal hypertrophy, which affects the basal anteroseptum mainly and the adjacent basal anterior segments. And there are some criteria for its diagnosis. The interventricular septal wall thickness should be more than 15 millimeter Hg measured at diastole. And there is another criteria, which is the ratio between the septal and the infralateral wall. This ratio should exceed 1.3 and 1.5 in hypertension to say that is asymmetric hypertrophic cardiomyopathy. The second important subtype is the symmetrical or concentric hypertrophic cardiomyopathy, and it is only diffuse left ventricular thickening. And is associated with decrease in the left ventricular cavity size, but should require the exclusion of other causes of the left ventricular wall thickening, the traditional causes as hypertension and the valvular aortic stenosis. And there is a nice subtype, which is the apical hypertrophic cardiomyopathy. It usually affects the apical segments of the myocardium and has a characteristic nice appearance of the ace of spades. It can be isolated apical involvement or mixed with the concomitant hypertrophy of the septum. And also its diagnosis, including that the apical wall thickness should be more than 15 millimeter Hg at diastole, and the ratio of the apical to the basal wall thickness should be more than 1.5. So we start with the echo, as usual. to confirm the left ventricular hypertrophy, the septal to the infralateral wall thickness, which we say before should be more than 1.3 and more than 1.5 in the presence of hypertension, and also the wall thickness, which should be more than 15 millimeter at diastole, and to detect the associations such as assessment of the LVOT obstruction, the systolic anterior motion, mid-cavitary obstruction, and also assessment of the systolic and the left systolic function and the left atrial size. First, we will talk about the associations and how we can diagnose them by the MRI. First, and the most important is the LVOT obstruction, the most important association. This is a 3-chamber view, which is the best for assessing the LVOT obstruction, as we will discuss later. The left ventricular outflow tract obstruction is defined as the impedance of the flow of the blood from the left ventricle to the systemic circulation due to the hypertrophied interventricular septum, which is usually at the basal segments. And by echo, it's defined as a gradient to be more than 30 millimeter Hg, and when more than 50 millimeter Hg, it is a threshold for hemodynamic significance. And we don't say that it is obstructive until there is actual obstruction, and it causes basal, it occurs at the basal interventricular septum, most commonly. So what are the theories or the causes for LVOT obstruction? Maybe due to abnormally thickened muscle, the heart muscle becomes excessively thickened in HCM, causing narrowing of the LVOT. Also, there is another associated factor, we'll discuss it later, the movement of the mitral valve. There is abnormal mitral valve movement in the HCM towards the LVOT, causing or adding more obstruction. And the overall dynamic movement, as the left ventricle dynamic motion, abnormality in the HCM plays a role in the LVOT obstruction. And its symptoms include chest discomfort, dyspnea, fatigue, and syncope. This is the other association, which is the systolic anterior motion that we talked about. Due to excessive musculature of the HCM, there is abnormal chordal attachment, and this abnormal chordal attachment causing the anterior mitral valve leaflet to move toward the left ventricular outflow tract during systole, which in the normal not happen. Normally, in the normal situation, the mitral valve during systole is closed, while here it's opened and moves towards the LVOT during systole, causing LVOT obstruction and hence decrease the coronary and the systemic blood flow. What is the cause of such abnormal movement? As we say, the abnormal chordal attachment is a factor. There is another factor, which is the excessive anterior or posterior leaflet tissue, which provide large surface area that cause drawing of the mitral valve to be moved anteriorly towards the left ventricular outflow tract. This is a video that demonstrates the systolic anterior motion of the mitral valve. This is a systolic anterior motion again of the mitral valve, of the anterior mitral valve leaflet towards the LVOT during systole. Also, there is another association that can be present, which is a mid-cavitary obstruction, as it is an obstruction within the mid portion of the left ventricle. It can be detected by echo and then confirmed by the MRI. So, what is the role of MRI in detection of the HCM, confirming the diagnosis and detection of associations and complications and help in management? We first will talk about the protocol taken. We will take our regular Cine images, Cine 4-chamber view, Cine 3-chamber, and Cine 2-chamber view. We'll take the Cine short axis view. And there is an important sequence that we take in HCM patients, which is a Q flow across the LVOT. We take sequential velocities across the LVOT. Starting, say, by 1.5 meter per second, and then rise gradual, half by half meter per second, till reaching the disappearance of the aliasing at the LVOT. When we reach the disappearance of the aliasing, this is the actual velocity across the LVOT. We'll take also the gadolinium enhancement sequence, early, delayed gadolinium enhancement, the T1 mapping, which is a numerical value for early prediction of the fibrosis. So what are the value of the aforementioned sequences? Our usual CINI images help to more precise assessment of the LV wall thickness and areas of hypertrophy, precise areas of hypertrophy. And as we said before, that it should be more than 15 millimeter during the stool. And the left ventricular systolic dysfunction, left ventricular hypertrophy, if it is associated with right ventricular hypertrophy or not. And so how we can detect the associations by MRI? The LVOT obstruction can be detected by two important sequences, which is the three-chamber view CINI image, as we said before. It appears as a dark jet flow of blood towards the LVOT, means that there is obstruction. The second important, as we said before, is the Q flow. When these are two Q flow sequences, here there is aliasing, and there is a disappearance of aliasing after we rise with the velocities. And when the velocity becomes more than 2.7 meters per second, this indicates the presence of LVOT obstruction. This is again the systolic anterior motion. This was a video, but unfortunately.
دكتورة منى 1 minute. شو هم الفيديو؟
Also, the important point is the detection of myocardial fibrosis by late gadolinium enhancement. The typical pattern for HCM is the mid-myocardial streaky or patchy mid-wall enhancement and along the ventricular insertion sites. It helps to do the scar quantification for assessment of the scar burden and for the sake of management of the patient. As we measure then the scar quantification to assess the scar burden, and when it reaches a certain value, it requires the ICD management, not the usual management of HCM patients. And also the assessment of mid-cavitary obstruction in the short axis CINI images. It will appear as near total or total disappearance of the cavity in the of the mid-cavity during systole. Also, the MRI has an important role in the differential diagnosis of the HCM patients. Like cardiac amyloidosis, it is a common restrictive cardiomyopathy, the systolic dysfunction. We'll notice decrease in the T1 and T2 signal intensity of the myocardium, diffused left ventricular wall thickening, and there is a specific sign for it, which is the thickening of the interatrial septum more than 6 millimeters. With biventricular diastolic dysfunction, and we can see pericardial and pleural effusions. And there is a typical pattern for the cardiac amyloidosis, which is a subendocardial post-gadolinium enhancement. The cardiac sarcoidosis has also a typical pattern in the late gadolinium enhancement, which is the mid-wall or epicardial sparing the subendocardial wall, and usually occurs at the basal heart, particularly at the septum and the lateral wall. The last is the Fabry disease, which is a multi-system disorder. It can also be differentiated by MRI criteria. The CINI images demonstrate left ventricular hypertrophy, increased left ventricular mass, increased papillary mass, and myocardial fibrosis, which has a very specific pattern involving the basal infralateral walls. This is a typical pattern for the fibrosis affecting the basal infralateral walls at Fabry disease. Thank you.
Thank you, Dr. Mona. Any questions for Dr. Mona?